I'm gonna
Yeah, give us a
it's
second.
closer
Here
to
we
you,
go.
yeah.
Yeah. So you want to pass by?
Oh, let's go here. Sorry.
All right. So here you can see, you guys, the axis here. There's no pancreatic parenchyma. There's some just artifact.
Where's the other cursor? Huh?
So you want to show them the PD? Here's the pancreatic.
Okay, so this is the PD here. So if you follow it and you follow it, and you kind of see probably there is some. So if you follow it, and up here. So it seems there's probably a communication just down here to the PD, which is expected in pseudocysts, and obviously this is how a pseudocyst develop. His question is whether there is any pancreatic tissue on the other side that can cause discontinuation. So that's the main question. I don't see any tissue, any pancreatic tissue on the upside, the upstream sides toward the tail. So in this patient, we know there is a communication with the PD, which is expected, which explains why the MLAs is always high in patients with pancreatic cyst or pseudocyst. But the main question, whether there is some parenchyma higher up here, which I don't see. So I think this patient is unlikely to have a disconnected duct, but you know, this will show with time, I guess. So I guess, Sad, you'll go ahead with the puncture. So we're using the Axia stent, 10 millimeter, just because it's a smaller cyst. So Saad is in. So this is the first step. The catheter is in. He's going to deploy the inner phalange now inside.
Remove the cautery, please. So always good to remove the cautery. So I go usually deep into the cyst, and then after that, I unlock my distal flange. So here we go.
All right, so here you can see the inner phalange, perfect.
And then after that, I try to snug it so we can get the football shape up to until the catheter touches one of the lips. Now I'm good. Now I'm gonna unlock, and then now I'm gonna deploy my endoscopic phalange, and then I usually unlock in this area, so I can have much more flexibility in terms of deployment.
So you do intra-channel deployment for the second phalange. So this is done blindly. And the next step is we'll switch endoscopy. If we can switch to the endoscopy image now.
Can we see the endoscopy view?
Yeah, so in 1 second, control, can we switch to endoscopy?
Guys, can you see endoscopy now?
Can we switch to endoscopy, please?
Okay, we'll wait for you guys. So we'd like to see the endoscopic picture, please, audio-visual.
Okay,
Yeah, there we go.
They have it? Okay, perfect.
All right.
So you can see the clear fluid already coming out, which is a good sign. And then you just move the scope, and then hopefully the phalange will open up.
So sometimes you need to kind of tug it away a little bit, a few times, and then you straighten your scope so you don't pull out the axius with you.
Perfect, yeah.
And then it's out.
So you can see very clear drainage. So it's a good location as well, so away from the GE junction, and you can see very good drainage. So the question now, as we've discussed, whether you should insert a coaxial plastic stent. So Saad, what do you think?
So there's 2 points out of it. So there's a paper that recently was published in GIE about leaving a double pigtail or not. It does decrease the rate of rebleeding. However, it's more with the 50 millimeter stents. The 10 millimeter stents, usually, because of the surface area is less, it depends on how early on you follow them up. So these patients, in all honesty, now I'm repeating imaging even next week, as close as next week, and then I remove the cyst quite early. For patients who I expect that they're not going to show up or something like that, I always leave a double pigtail because, you know, once the cyst collapses, there's risk of bleeding back in the back cyst of wall compared to the sharp edges of the stent itself.
So the decision is not to place a
No, I
plastic
think it
stent
should
here?
be fine.
Okay, so as long as you follow the patient very closely, and that's the most important aspect whenever you place an axius or any lumen opposing stent, really you need to follow the patient very, very closely, because complication will only happen if you lose follow-up with these patients.
Yeah, I mean, it's always nice to look into the EUS image of the
You can switch to,
proximal flange. Can you show one?
yeah, so we'll switch EUS again.